Right, welcome back, everybody. We're excited to continue with today's session. Please remember to use the chat function or raise your hand if you have a question during the Q&A portion, or you can even put questions in there as we're going along. And we'll get started. So it's my pleasure to introduce our next presenter, Dr. Mahesh Nagappa. Mahesh is an anesthesiologist, associate professor, and director of research and innovation at the Schulich School of Medicine and Dentistry at Western University. Mahesh will be presenting a pragmatic stepped wedge cluster randomized trial on the implementation of a multifaceted opioid use reduction strategy for Southwestern Ontario. So please join me in welcoming Dr. Mahesh Nagappa. You take it away. I'll stop sharing. There you go.
Thank you, Kathleen. Good afternoon, everyone. My project is on implementation of opioid use reduction strategy for London hospitals. We have 3 hospitals across the city, and it's a pragmatic stepped wedge cluster randomized controlled trial. So going to the research question or the objective, the main objective of this research is does using a patient education on how to use opioids and helping them with the pain management, does it really help to reduce the total community opioid exposure and the opioid related harms? We're going to use some technology to do this. That's the main part of the intervention. And it's more an interactive intervention. The final objective is to reduce the total community opioid exposure in the society. A little bit of background why this trial is needed right now. If we track the process in the perioperative pathway, once the patient is diagnosed with some issues or concerns, they are posted for the surgery. And once they get discharged, they'll have a postoperative pain, and they are prescribed some opioids to go along with home. These opioids are very helpful to control the pain and to improve their quality of life. Unfortunately, it also carries some side effects, risk of addiction. There is always some small risk of misuse and diversion, and some overdose and death risk is also there if not appropriately used. This trial is a little bit of more enhanced background here. There are some opioid crisis issues, both locally as well as national. Especially our part of the province is tagged as the hotspots for the opioid crisis. And uh, we uh, we came to know that prescribing opioids and educating the patients on opioid consumption in the postoperative period can make some kind of decreased societal exposure to these opioids. And we also provide some support to the patients how to manage their pain. This will help to go more with non-opioid choices as the first option and stick to the opioids as the next option if the pains are moderate and severe. So this is a large, pragmatic, high-quality randomized controlled trial that is lacking in the literature. And we also wanted to have a good sample size so that it can be generalizable to all other centers. So we wanted to pick an adequate statistical power, and we want to detect some meaningful change in reducing the total community opioid exposure and the opioid-related harms in this population. So if we go with the PICOTS, our population is any adult patients undergoing a surgical procedure during the study period. And the intervention is an automated patient engaged education via the app on the consumption of opioid and the pain management. The comparison is the current standard of care. We have primary outcome and secondary outcome. The primary outcome is the oral morphine milliequivalents, total community exposure to the society. And the secondary outcomes are the composite outcomes of days alive, out of hospital, opioid free at 90 days. So this takes multiple outcomes into clubs into one single composite outcome. The trial has been designed as a pragmatic stepped wedge cluster randomized control trial, and the setting is the perioperative period. We have few other secondary outcomes. Those are ED visits and readmission rates at two different time intervals, 30 days and 90 days. And also we want to see how many patients still use the opioids even after 3 months. Those are tagged as the chronic opioid users. And we wanted to collect collectively the side effects of the serious opioid related events as well. We initially, when we designed, we had 30 days and 90 days family physician visits as well, because our patients go for stitches removal on 10 to 14 days after the surgery. We had to remove this outcome. So the current standard of care is there is no formal 1:1 patient education on opioid usage unless they are chronic opioid users, or just the normal standard education as a part of the preoperative visits. Otherwise, there is no clear 1:1 education on this opioid consumption. We have some brochures and verbal instructions given, and some kind of support back to the surgical teams office, and patients usually go to the ED visits if they have a severe pain and if they need any opioids. That's the normal standard of care. What we are proposing through this intervention is we are going to use the technology to educate the patients on opioids and the pain management. And we want to slowly expand this to 3 hospitals across the London. And we preferred a cluster RCT design because we are randomizing the hospitals here, and we choose the step wedge design as well. When we designed originally for larger number of hospitals across the province, we got the waiver of consent from the REB. We are hoping that we get the waiver of consent for this narrower, lesser hospitals as well. As described, the inclusion criteria is any patient, adult patient undergoing an elective surgical procedure, and exclusion criteria is none. Um, so as I said, the control group is the standard of care. This will provide the baseline data in this type of design, and the treatment group will go with the patient education. The education is all about setting the expectation about the pain and the consumption of the opioids, educating them about the multimodal usage of opioids, how to dispose the opioids safely, and this is all happens automatically through an app based program. And there are some self education and self management tips as well. It will also say with an algorithm like when to go to the ED visits or call the primary care provider. So since it's a stepped wedge design, this is mainly used for the service delivery type of intervention. So once the intervention is turned on in a site, it remains on for the duration of the study. Um, so we have 4 hospitals across the city. The third one is really a very small hospital with only 2 operating rooms, not a big sample size there, but we have included that as well to avoid the contamination. And each one will be for 2 months, we'll collect a baseline data, and then we'll randomize the hospital and then start the process of um, streamlining the intervention. And once the first hospital is enrolled, and every 2 months the next hospital will be enrolled, like that for over a period of 10 months. So the study region is like the citywide London hospitals are for 4 hospitals. We have a big volume of around 45 to 50,000 surgical patients per financial year. So we are planning to conduct this for over a period of 10 months. So we are expecting a sample size of are anywhere between 35 to 40,000. The allocation is cluster randomized. Intervention is step-based design, and um, the analysis is we are planning to do an intervention to treat with a GLMM model and a linear mixed method control. What this does is it will take into the consideration about the patient's baseline characteristics as well as the time of the intervention, and it will calculate the odds ratio. Since there is no risk involved with the intervention and other criteria won't fit, we have no DSMB and no interim analysis is done for this um, pragmatic trial. Why we say this as pragmatic? Because it maximizes the external validity, and we will come to know how the strategy can work under the actual system constraints. And we want to capture more of an effectiveness of the policy. And out of a scale of 1 to 5, 1 is more exploratory and 5 is more pragmatic. You can see majority of it meets the criteria for the pragmatic work in our trial. So this is more of an implementing the policy and less of the testing the efficacy with the intervention, and it mimics the real world policy adaptation rather than having a parallel two group experimentation. Regarding the feasibility and the operational finding, we have some preliminary work going on the data collection process, thanks to our Western and the Schulich ISIS team through the ISIS database. And we also did a very small pilot RCT on how this patient used the app. You can see out of 40 patients, 37 patients were fully compliant and completed the analysis. And we also executed some ideas like what are the main concerns bringing these patients to the ED visits, readmission rates, and concerns at home. You can see the pain issues are top, like 23% in the post-discharge period. We also tested our app, and you can see almost 100%, it reaches 100% compliance with the use of the app. We also did a systematic review of the intervention in the literature. We got around 28 studies with around close to 4,000 patients. Most of these educations are written educations or verbal educations or multimedia education or the mixed method education. And majority of these educations found that there is reduced consumption of the opioids, and in very less number of studies there was no change in the opioid consumption. So looking at these interventions, we thought it will be practically very difficult to do a 1:1 education because we don't have the access of all peri-op patients to the pre-admission clinic. There is issues with the flow delays and financial issues and staff dissatisfaction, burnout. Considering all those factors, we went for an app-based education um, to provide the maximum impact to the patients. Everything was not perfect with our pilot work. Not all patients had an iPhone. Not every patient had a smartphone, but one of the family members always had some smartphone, and they came forward to help their family members during the recovery process. And some patients had an issues with downloading the app, and some patients had language problems, and we had very tough time, almost failures in patients with delirium to enroll into the app program. And other category of patients, when they are from the healthcare side, they said they already know how to manage pain, and they didn't want to get enrolled into the program. I would like to convey my sincere thanks to Amit Garg, Jeanette Martin, and Joel, and for Amoso AFP Innovation Fund for providing the fund for doing the ISIS data collection. And also thanks to the Pragmatic Trial team for the wonderful videos and inspiring work on this program. And thanks to Lauren, Yasmin, and Sarah for their help with all the Pragmatic Trials training program. Thank you so much.
Thank you, Mahesh, for that wonderful presentation. So now we're going to move on to our panel discussion. So we've got two experts joining us. So joining us today are Dr. Jeff Bellingham, who's an anesthesiologist, pain medicine specialist, associate professor, and director of the pain medicine residency program at the Schulich School of Medicine and Dentistry, and Dr. Stephen Kuchar, who's a postdoctoral fellow within the clinical research unit at the Children's Hospital of Eastern Ontario's Research Institute, specializing in pharmacoepidemiology, Bayesian analysis, and comparative effectiveness research. So I'll hand it over to our panel.
Great. Thank you very much. Am I coming through loud and clear?
Yes.
Perfect. Yeah.
Yep.
Well, thank you, Dr. Nagappa. It's important work, especially working here in London, Ontario, seeing a lot of folks on opioids in our chronic pain clinic. And certainly it happens when they are prescribed after operations. So, we've definitely seen this as a big challenge over the years. And there have been, initiatives to try to improve opioid stewardship. So, for example, in about 2018, 2019, the orders for opioids, if you hit an acute order, it's going to give you 3 days of supply only, and this was intended to try to limit the amount of opioids getting out to a patient or the community. There have been some local research initiatives. For example, Dr. Ken Leslie from surgery, Dr. Colin Clark, one of my colleagues in the pain clinic, worked on a standardized outpatient procedure to try to reduce narcotics or opioids. It was also based on patient education as well as clinician education as well. And, as you know, in 2020, Hans Clark and his group from Toronto has put out a consensus-based guidance for perioperative opioid prescribing. So I think there's a lot of great work being done. There's a lot of strong initiatives, and there's a foundation here. So I would like to ask, can you clarify how the proposed intervention you have, the app, is going to perhaps build on rather than maybe duplicate some prior work or maybe even conflict a little bit with some recommendations? And my secondary question is, how could we, or could you suggest, or is there something in your protocol that would make this truly sustainable beyond what's already being achieved? Because some of these initiatives, they're very good, but then, maybe after a couple of years, residents graduate, you don't remember why certain things were put in place. For example, the cap on the opioids in our pre-printed orders. I think a lot of people coming through our system now don't even know why that's there, perhaps. So I was wondering how you could comment on that, or maybe help us to understand a bit further this intervention based on everything that has been done before.
Thanks, Jeff. Thanks. That's a very important question. So compared to the prior work, like when we originally designed this study, we wanted capping of opioids as one of the intervention, along with the patient education. But when we worked on it for a couple of years, we found that it's not going to be sustainable, and also our work was not progressing anywhere. So we wanted to keep the intervention very simple and straightforward, no risk to the patient, and still provide the maximum impact. So based on that discussion, we removed the capping of the opioids, And we found that finally it is the patient who are going to use the opioids. They are the final destination. They are the one who are going to either use or not use the opioids. So we thought when we educate the healthcare providers, like it may not be sustainable. Once we do some teaching or capping, all those things may work for some time and slowly it may just fall off. And then finally it ends up to the patients once again. So we thought with the app, when we saw in the literature, with the app, they can track, they fill their own opioids, like today, how what they took, like Tylenol, ibuprofen, and 2 milligram of hydromorphone. And when the healthcare provider calls them, or when the patient reaches back to the healthcare provider, they'll say, I used opioids like 5 days back, but now my pain has gone up. And everybody can see that and in a graphical way that how the opioid consumption has gone down or up. When it has gone up, they will always think of some hidden complications and then we intervene the patient. So what I would like to say is there is a two-way communication option with this app. The patients can ask the question, and that question is available to the surgical team, nurse practitioners, and whoever is involved in the care, and it can be embedded into the power chart as well, so that next day morning when they open the chart and if they see any questions from the patient, hey, this patient needs the help, and someone will jump into it and then they will provide the necessary intervention to bring the patient back on track.
Thank you.
Mahesh, could you just stop sharing your slides for the
Oh,
moment?
yeah,
Thank
sure.
you. And then we can see your videos a little bit bigger.
Thanks again, Mahesh. First, I'd like to echo Dr. Bellington's comments and thanking you for your presentation. We obviously really appreciate you for your dedication to this pressing issue. I'm going to take a little more probably methodological lens because I don't have the same background as you both in this. So it looks like Dr. Bellington and I are going to go back and forth and kind of take you on a road of content and methodological for a little roller coaster ride. So mine is going to be more about you chose the step wedge design for your cluster randomized trial. What I wonder if you can describe the process that kind of led you to that decision and maybe help the audience because I've actually never done one. And so I'm less familiar with them and I've read on them and I've often led people away from them, but there are some pros to when you use them. I wonder if you can talk about what aspect or aspects of your study that led you to choose this one over, say, a parallel cluster trial.
Thanks, Stephen. That's very good question from the method section side. So when we wanted to design a normal parallel group randomized control trial, we didn't want this trial to take a direction of funding, publication, and then forget. Like after 10 years down the line, if somebody asks, like, have you implemented this work? If the answer is no, then we may not um, we may not get the right reward for the work we have done. So we were looking more in terms of an implementation strategy, and also we wanted as an RCT as well, so that we can collect the good evidence. And the other reason was about the sample size. For example, if we go for a parallel design, then the sample size needed, our expectations were on the bigger sample size. Then you need to go for research, recruitment, randomization at the patient level. The cost of the RCT will go up as well. So mainly to reduce the cost and to make sure it goes in a one-way implementation side, we went for the step wedge cluster RCT.
If I can just follow up with that before I give you back to you, Jeff, and thanks for making that response because that's I think I didn't have the chance to go through your sample size and digest the numbers and compare them in detail. And I'm wondering if because when I had read I got the benefit of reading a bit of your protocol unlike everyone else here that just got to see your presentation. And I think that's might what lacked to me in it is that you didn't justify that. I think that's your golden kind of goose there is that the sample size might be the important thing and why the step wedge benefit. Because it sounds like you have four institutions and you get a large sample size. And so you'd only, if you randomize parallel, you'd only have two and two essentially, right? And there might be
Yeah.
a large samples within those big clusters, which aren't necessarily more efficient. You want smaller clusters. And maybe that's what you will really sell the choice for this for me. Because the implementation one, I see it as if you prove that it works, I feel like people will use it, right? If people think it's an easy thing to do, to me, I'm not worried about them taking on something that helps. And so I think you really sell me with this sample size argument there. And so I think that's a great thing that you should really expand on when you write your protocol is it helps justify your choice.
Thanks, Stephen. Yeah.
Great, thank you. So, can I just get back to the functionality of the app? In fact, you had mentioned that there is an option for patients to reach out to their surgical team or healthcare providers. Is correct?
Yeah.
Okay. Yeah. No. So I think that's really quite novel because in different projects that I've seen, local ones as well, that sort of two-way communication may not necessarily be available. And I think that might be something really interesting and pretty impactful, in fact. So the one question I have about that is, sometimes questions that patients may have around opioid use can be really quite challenging. And, I might be a bit biased here because I working in a chronic pain clinic. The types of challenges sometimes we get are, if you just give me, 10 per day, not 8 per day, my pain's 100% gone. Or, you've done a surgery, it's gone wrong, you've got to give me more opioids. Or, I might, if you don't, I'm going to go to the street and you're going to be making me do something illegal. I mean, those are pretty extreme examples. However, they're realistic. They may not be frequent. So I guess my question is, how is this going to be structured? Because I've learned one thing from clinical work and being part of a clinic. If you're going to offer something, you better be ready to provide it, and it should be there ready to go. So is there any turnaround time that is expected when a patient uses this functionality? For example, are they going to get reply in 1 day, 2 days, day of? And additionally, when those difficult questions come up, is there going to be an opportunity for a clinician or some healthcare professional with experience in managing opioids to be able to try to manage those types of difficult questions? Because when we're dealing with opioids, I always tell our trainees, takes a lot of clinical bandwidth. It's a lot of time and effort for a very small proportion of your patients, but it is a lot of work. So could you please speak to that? I'm really interested to know more about that functionality.
Thanks, Jeff. So I can quote you a couple of examples here. So basically, the current standard of care is something happens to the patient, for example, the increased pain, and then they call the surgeon's office or go to the emergency department, and then somebody from the healthcare, they react to it. With this app, it is more of a proactive approach where specific messages will go to the patient so that they know exactly what's the expectation, like when the pain will fall off, person with a similar type of surgery, how long they had used the opioids. Those type of informations are there, which may be helpful to some category of patients. Regarding the two-way communication, Jeff, for example, one of our patients had texted saying that I have a severe shoulder pain after a VATS procedure. And they send the text message after, say, 4 p.m. Now, we have a clinical navigator who comes and sees that question and says, this shoulder pain is very normal after this type of procedure, like thoraco VATS procedure. And immediately the patient responds, oh, somebody should have told me. I never knew this. The problem is settled there. Otherwise, that simple thing constantly beats around the bush for the patient. Patient uses opioids and other issues. And like that, when they use the opioids and say they're running out of opioids, they'll say, I will be running out of my opioids tomorrow afternoon. Is there a way I can get a refill? I still have substantial pain. You can see my pain scores, and we can track the opioids patient had filled. Like I gave 18 tablets, 1 milligram, all 18 will get over by tomorrow afternoon. And the question is very fair enough by the patient. And we can give a quick call to the patient, and then somebody can refill the opioids. With this program, we didn't want to increase any manpower work. That's why our final goal is to implement this app into the power chart, so that the power chart will have the access to all the primary healthcare providers and others. Basically, we want to bring the nurse practitioners, the floor nurse practitioners, as well as the pain service team, and then a clinical navigator who manages the dashboard and addresses according to the flag. Like if she thinks somebody's question is very relevant, that will be answered first. If somebody's question is not relevant, then she will just keep it to the side to be answered at a later stage. So this expectation is also created for the patient, that their answers need not be like answered immediately. It will be addressed like at by next day morning according to the priorities. And we want to see when it scales up, like how this workload is managed. Those are some still question marks pending.
Yeah, and just a follow up comment slash question quickly. I think it's an interesting component to this app. And had there been any consideration to maybe cataloging or gathering the types of questions that are coming out, so that in the future you can anticipate where the education gaps that can be brought up sooner rather than later, proactively?
Jeff, can you please repeat me the question?
I apologize. Am I coming through okay?
Yes, yeah.
Yeah, so just briefly, has there been any consideration to cataloging the types of questions that are coming through the app, so that this can maybe be used in the future to inform teams, well, where are the knowledge gaps for patients that can be educated ahead of time, so that there's much better understanding of postoperative pain?
Thanks, Jeff. Yeah, definitely, we're keeping the track of the issues related to the pain in this pilot program. Um, um, we found that like when patient receives the brochures and in the written form, like a 40-page information, like nobody reads it. When we make that in a very incremental way over a period of time, sending as a messages to the patient, that really sinks into their mind. Yeah, we are just keeping track of some of the issues, so that we can backtrack and implement in the peri-op pathway.
So not to take you off, I'm going to try and stay on the intervention questions that I have, just to kind of keep you on topic for a bit here. And you were talking about this app, and I noticed that in the stuff that I got before the presentation, there was some talk of, and like I think you mentioned, you're presenting some brochures, some verbal instructions to patients as well. Can you help me understand a bit better what level the intervention is at? Because you've mentioned, I saw in different places sometimes a patient level suggested intervention with the app. Is there anything that's happening at the clinician level? Because I know in some of the documents there was a educational tool for providers. And is there anything happening at the institutions? Because there's essentially three different possible places for the intervention: the individual, clinician, and the institution. And I was wondering if you could describe where the intervention fits into all that.
Yeah, thanks, Stephen. So that was the original intervention we had, three components. We felt that intervention is very complex, and we really struggled with capping of opioid. That intervention was we really needed that intervention, but unfortunately, we were not able to execute that at the hospital level due to the various reasons, and our study was not going anywhere. Keeping that intervention in place, we wanted that, but it was not happening. Every time it was circling back, and finally we decided, let's keep the intervention very simple. Even if capping is done, there will be a lot of other issues. And our population in the peri-op is very mixed population. Like some people need more opioids, some people need less opioid. So capping the opioids may not work in the pragmatically in the real world. And so that's why we took off that intervention. And the other intervention was the healthcare provider education. We were thinking of providing lectures and some kind of educational information, grand rounds, and connecting with the multidisciplinary surgical team, nursing team, and other stuff. That also we felt it may work for some months and then slowly it may fall off. The sustainability was in question mark. So we really wanted to bring something once we switch on, like it should get sustained and carried over the period of time to see the results. So we took off those two interventions and finally stick to just the patient education.
I see, I see. So it's just the app to the patient, not
Patient,
to
yeah.
any providers. Okay. And then obviously there seems to be some potential for interaction with the provider though, so they have to be, I guess, aware of that aspect. And if you don't mind, if I'll just follow up quickly, you're going to implement this then. And is there any length of time you expect for like there to be an improvement or in your outcome of interest, your primary outcome? As in like, is there like a lead-in period, sort of like a washout period from when you transition from unexposed to exposed, so that when you're capturing, let's say you start at the start of this month, but it takes, let's say you expect it 1 month, you'll be underexposed, but you won't have fully achieved the intervention yet to improve anything. So if you have any outcomes you measure, they won't be under the they won't be under actually under the intervention. They'd be under the pre-intervention. So is there any like period of time you thought about that timing?
Yeah. Yeah. When we choose the app, we choose like a 30-day program, but still the app is open and the information, educational materials, everything is accessible to the patient after 30 days, but they just lose the two-way communication. They have to just go to the family doctor or ED visits after 30 days. So when we analyze the data, when these patients are having the maximum ED visits and readmission rates, we found that bell-shaped curve like going 7 to 14 days. That's the highest risk for ED visits and readmission rates after the hospital discharge. So we scaled it to like 30 days. That may provide a good extra window, and then after 30 days it may not be needed to give much support regarding this intervention.
Thanks for further clarity there. I just wanted to bring it back a little bit to the clinician side of things. I definitely understand the issue, the concerns, I guess, with sustainability and educating people, for example, grand rounds or emails, for example. Now, when I read the protocol that in advance, I did see, and I saw that you've amended this, was the family physician visits. And the one thing that I was excited about when I read it was, okay, great, the family physicians are going to be involved in this, because, you know, the part of the concern that you've outlined is the fact that opioids are being prescribed well beyond when they're supposed to, right? And again, it could be a small percentage of patients, but given a very large sample size, you know, it and in absolute numbers, it's going to be a lot. So I wonder if you could maybe comment on how family physicians can be involved in this project, because I think it's really important, because those are the people who are going to answer the questions after the 30-day communication trial, or the communication component of the app is shut down. They're the ones who are going to be responding to, I still have pain, I need a renewal. They're the ones who are going to be renewing the opioids as well. So, although I hear what you're saying about the sustainability, I always get worried that patients get caught up in what I call this consultant sphere. They see consultant, 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 and sometimes I ask, well, when was the last time you talked to your family doctor about what's going on? It's been a long time. And the family doctors have no idea what's happening unless they're being copied on documentation. So I really think that bringing the family physician component in can be really helpful, very useful. And had that ever entered into some of the considerations for design of the trial? And what are your considerations regarding bringing the family healthcare teams into this? Is it something that should be, or do you feel as though, much like the education for the hospital, may not be as needed?
Thanks, Jeff. Thanks for that question. When we designed this study, or we reached out to the head of the family doctor. I don't know who was that. And it was discussed and brought to their issue how they can contribute or how they can share some ideas. We can make it work and expand to them. Um, it became more and more complex, and then we just stopped um, involving the family docs into this. And there was another stage of the study design where there was a proxy where patients can share their app information with their family doctor, like a proxy sharing. That option is there in the app. Um, we haven't tried it. I don't know. It's really a good question. Something to think for future. I completely agree with you. A more integrated and coordinated care will make it better.
That's great. I'm really happy that you did reach out to the family physicians, because it's, whenever I do, it's just great progress. It's great communication, and really resolves a lot of patient related concerns. So okay, yeah, okay. Well, that's something that has been approached. So thank you for answering that question.
Thanks, Jeff.
So now I think I'm gonna go towards the outcome measurement. So there's kind of a string of small questions, and maybe they're quick to answer, maybe they're more complex. I'm not sure, but hopefully, Mahesh, you know how to answer these or have some insight that I don't. I think you mentioned you wanted to use the provincial database to do the follow-up for the outcomes. So morphine equivalent, how are they measured in the ICS system? Like how are they captured?
Yeah, I don't have much idea. Lauren is helping me with that ISIS database, and we did some coding. And apart from that, I'm completely illiterate on that side.
Okay, because like my concern there is that often in my experience, especially if it's outpatient, I'm assuming you're going for prescriptions that are filled. And
Yeah.
typically that'll only be for those that are 65 plus that'll be captured at a decent amount because it's the public health care system. Private insurance won't be in the ICS data. And so yeah, I know your inclusion's 18 plus, but I'm not sure how much you're going to get from under 65 for morphine equivalent measurements under that 65 age group. So just to keep in mind, you may have to make an adjustment. Not that you don't want under 65, but that data may not be there at a reliable amount that will represent that population potentially.
Oh, yes. I remember we're using a narcotic database. I don't know the exact name of the database system.
Okay.
That gets updated like 3 months. Every 3 months it gets updated, and then that can capture all the information. That's what I remember through our discussions.
So they capture the narcotics in a different way than they do typically the other medications?
Yes, yes, but
Okay.
it captures all of them, but there will be a lag period between
Of course.
the time. Yeah.
No, no, I understand that. I know that the databases aren't instantaneous and there's always a time lag to when they're available. I did my PhD using some provincial databases. I remember waiting. And then with that, you talk about we're talking about opioids, like in the amount, the cumulative dose. Are there any plans to measure like pain scores somehow from the participants? Because you might be reducing their use, but what if their pain management is not as effective as it was prior? And I'm curious if there's any way that you can speak to that.
Yeah, that's the beauty of the app. Like it doesn't need any extra manpower from the healthcare system. No office space is needed, no financial expenditure. All data is entered by the patient. Like today, my pain score is say 6, and then tomorrow they'll enter. Day after tomorrow they'll enter. So once the patient finishes the program, you can beautifully see the graph like over a period of 30 days how the pain scores have gone down. Not only the pain score, we capture the anxiety, mood, and the opioid consumption. And patient themselves, they'll say, I stopped using opioids like 5 days back. You can see my pain scores are 4. uh, Most of the time the pain scores goes up. They reach out for help, and if you start to investigate why the pain score went up, they will say, I went to start cleaning my kitchen, I started gardening. And then you will say, oh, that's too early, you shouldn't have done that type of work at this time of your recovery. And then they'll understand, and the rest and non-opioid measure, even couple of opioid pills, that should settle. That piece of education will go to the patient that they should not do that type of activity, and it settles there.
So they're going to interact with the app, and you're expecting like a daily interaction. Is that
Yes.
what that is? And then,
Yeah.
so I mean, not to say that that sounds lovely. I know in my experience, passive data collection from patients is, hope for the best, and it's not always there. So what type of missiness do you expect for someone expected to use an app daily for 30 days?
Yeah, there is um, like a compliance rate is not 100%. You will obviously miss some data points at certain days. But still, with considering the big sample size and a cumulative data point, it will be very helpful. That's our impression. And the other issue with the app is like it prompts them to fill the questions at a specific time, and you can adjust that time as well. And the deadline is like 11 p.m. for the day. Before that they have to do it, otherwise they can't enter the missing data the next day.
Thanks. Just a quick follow-up from where Stephen was asking, just regarding the outcome. I had considered, what are you going to do for those who are chronic opioid medication users? For example, methadone, any other controlled release, buprenorphine products as well. How does that get incorporated into the analysis?
Currently, we had the clinical navigator support from the hospital for the pilot work. Um, Unfortunately, the we didn't have like a much chronic pain patients. I do remember a couple of them. Maybe for one financial year, we had just 1 or 2 patients like that, and we refer them back to either the primary healthcare provider or to the family doctor. And we will also create a good expectation to the patient, like we are going to help only this much, and anything out of this range, like they have to still reach out to their routine follow-ups and other primary doctors.
Sure. I guess my question is, for those who are taking chronic daily opioids prior to their surgeries and during the intervention, are you going to be somehow taking the difference in opioid equivalents and seeing whether or not they get back to baseline, perhaps?
No, Jeff, we are like we're not trying to do any kind of radical changes in their opioid consumption. If it is like, for example, somebody taking methadone and very big doses of hydromorphone, we will know our limitations and try to scale it down. And we'll tell the patient that we are there to support you in terms of adjusting their appointments and other stuff, connecting with the surgical team. Um, but we won't make any big changes in their opioid consumptions.
Thank you.
All, all
I
right, I'm
wonder.
gonna. I
Can I
have
have one
to.
quick follow-up
Okay,
there, Caitlin? Yeah, and
one
then
last question. Yeah.
yeah, and it's kind of related to this because I think Mahesh, you're mentioning like and Jeff, your question is if they come in theory, and the randomization works, you should have the same in both. And so on average, they should have hopefully the same with the pre-existing beforehand. So that's one way of accepting that it's hopefully balanced. But with the analysis question in your protocol, you mentioned you were going to adjust for covariates.
Yeah.
And you didn't really have a pre-specified list. Do you still plan to adjust? And are there any predictors that you really think that are important to that predict the opioid use? Because I think you shouldn't just list endless covariates. You should focus on ones that you think are best.
Yeah, thanks, Stephen. I remember in the current ISIS database collection trial we are doing, chronic pain patients are one of them that we have included as a like a subgroup analysis. Yeah, that is there. That will provide some kind of insight. What is the incidence of chronic pain in certain surgical pathways, and how we can reduce it, and how we can provide some kind of support. All those things can provide really good insights.
Go ahead, Caitlin. I see there's lots of great questions from the audience.
Great. Well, thank you very much, Jeff and Stephen, for your discussion. So Mahesh will switch into answering some questions from the audience. So the first question in the chat says, "Excellent presentation, Mahesh. Regarding the data and safety monitoring board, since you're not planning to have one, how do you intend to justify that in the trial protocol?"
Yeah, thanks, Manali. Thank you for that question. I do remember we had certain criterias for DSMB. I don't remember them, but none of the criterias um, were checked. Like all of them were cleared for our protocol. Like none of them were really bothering our protocol to have a DSMB in the trial. I went through all the points and all of them satisfied good for us.
Okay. Right. The next comment is, or question is, very interesting work, Mahesh. I was curious, based on your pilot study, what proportion of patients owned a smartphone overall, and how did this vary by age group? So less than 65 or 65 plus. And were you also able to compare the characteristics of patients who had a smartphone versus those who did not?
Yeah, thank you so much, Jeffrey, for this question. Before we started this one, we thought the younger population might use the app really nicely, and we might struggle with the older patient. But when we actually did the work, it was exactly 180 degrees opposite. The older population really used, even though they had troubles, like they reached out for help, and most of the patients had an initial difficulty, but once they started using it, it was very simple and easy, and it was like an addiction. Like once they saw that it was helping them to see the results, like every day they were progressing with good recovery, with the pain scores coming down, they started using it more and more. The compliance rate went up as well. On the other side, we have seen like less than 20 years, like 19, 20, much younger population. They are busy going to the universities and other stuff. When you tell them to use the app, there is always a backward step from them. And some people, they start to use it, but their compliance rate goes down in the 30 days program. So compliance is something like that needs to be improved. We don't know. We're working on it currently. The other question is, were you able to compare the characteristic of the patients who had the smartphone versus who did not? So if it is an iPhone, it works very nicely. If it is an other smartphones, sometimes you need to tell the patient to update it, and then immediately it will work. Sometimes you need grandkids or somebody, in-laws or somebody should jump in and help them, and then it works. Definitely there are initial difficulties to get them on track, but once they are on track, it just runs very smoothly, and it's very addicting as well, as I said.
That's great. Um, The next question was, are you using any specific questionnaires to capture anxiety and mood?
Yes, these are questions designed by already in the app itself. There is an option to modify those questions. There are specific charges for it if they work for 1 hour hourly based charge. Like you can add information, you can remove information. The app people will charge the uh, per hour dollars for that. Currently, we are using their designed questions on the mood and anxiety.
Okay, so the ones that are within the app.
Yes, yeah.
Uh, Gordon's asking, is there any scope to prompt responses from participants via text, email, or phone call? And so it sounded like they do get reminded at 11 p.m., you were saying, I think.
Yes. So you can adjust the questions going to the patients what time to what time in the day. And the reminders also you can set if they don't answer, like how frequently you can send the reminders. Like when you see the dashboard, you will see a bunch of answers coming in the morning. Like some patients get up in the morning, answer the questions, then there is no capture for some time, and once again in the afternoon there is bunch of responses coming in there to the dashboard, and that happens once again in the evening as well. So like you will see a pattern of questions coming, answers from the patients.
Gotcha. Okay, I think the last question is, could you let us know the reasons to go with the consent waiver option in your trial?
Um yes. So once again, there are specific criterias in the literature for the consent waiver option. Um, so I had to get those meet those criterias, and then I had a meeting with the REB, and I don't specifically remember those points. There are like 6 to 10 points are there which are published data in the literature, and if you satisfy those criterias and convince the REB, we did a presentation to the REB as well, and as you guys can see, the risk and other issues, the and also about the funding, like the recruitment is the main chunk of the money goes to. So the REB said like you can still um, provide a patient facing information that this trial is going on. If you are undergoing this procedure in this hospital, you are automatically enrolled into this trial and the data will be collected like that. The information can be provided to the patient, and if you basically meet those criteria, those points to the REB, it will work.
Okay, great. And the last three comments there are around ways to help get people complete the app components. So gamification, maybe offering incentives at the end of the 30-day period, like a Tim Hortons gift card. And then a compliance incentive is a good idea is another article linked there. So sounds like that might be a good idea to consider including.
Yes, yes, that's a good idea. But what we have seen is the patients really feel they are connected to the hospital. I do remember a patient who was 11 hours away from the hospital from London, and still she was connected with us. And when we say them on the last day that this is the last day of the program and you need to go to the family doctor or ED for any other concerns, 1 2 3 like that, when we say that, they really feel emotional, like I'm very thankful, like it was great, and they see the real benefit, because there was benefit to the patient, like we didn't add any incentive to them. But if we get good funding, we'll definitely add it.
Yes, that is the challenge. You need the funding. Okay, thank you, Mahesh, for your presentation and answering all the questions. We'll just wrap up for the end of the day here. So thank you to all our speakers, panelists and participants for a thoughtful and engaging day. We look forward to seeing you next week for presentations from Doctors Kyla Naylor and Benita Hosseini. So be sure to check the agenda for all of the details. I hope you have a wonderful rest of your day and hope to see you again next week. Thanks everybody for joining, and take care.